Hello everyone, we're from PBL Group 2, and today we'll be presenting our views and findings for Case 2. A little recap from the case is that Mrs. B is a 26-year-old housewife who has a strong family history of type 2 diabetes. She has been married for 3 years but has no child yet. She seldom goes for exercise, and she frequently snacks when she feels bored at home. She was found to have a random blood sugar of 12 millimoles per liter during a checkup, and her HbA1c was 8%. On examination, she weighed 80 kilos, her height was 155 centimeters, and her blood pressure was 150 over 90 millimeters mercury.
The three antidiabetic medications that we have chosen for Mrs. B are metformin, SGLT2 inhibitors, and also GLP-1 analog. Metformin is the main drug chosen because it is the first-line antidiabetic medication in type 2 diabetes mellitus, which is Mrs. B's case. Metformin is cheap, safe, as can be given to pregnant and breastfeeding mothers, and has a very low hypoglycemic risk. Metformin acts by reducing gluconeogenesis and lipogenesis, making it the most efficacious at reducing HbA1c. Metformin is also known to promote weight loss by increasing fat thermogenesis, decreasing food intake, and improving gastrointestinal physiology. The next drug chosen is SGLT2 inhibitors. It works through blocking the reabsorption of glucose by the kidneys while also increasing glucose excretion, leading to lower blood glucose levels. It has positive effects towards hypertension as SGLT2 inhibitors are known to decrease systolic and diastolic blood pressure, thus also reducing risk of cardiovascular diseases. They also cause weight loss. GLP-1 analog is the third drug chosen as it contains a dual effect of improving glycemic control as well as promoting weight loss. In terms of improving glycemic control, it acts by increasing insulin secretion and reducing glucagon secretion, and has shown to restore beta cells function. The two mechanisms in how GLP-1 also promotes weight loss is by suppressing gastric emptying through inhibiting peristalsis of the stomach and increasing tonic contraction of the pyloric region. It also induces satiety by influencing brain regions involved in feeding regulation.
First, her obesity. She can start on by low-calorie and low-fat diet. With this, she can lose 5 to 10% of her body weight. To improve her sedentary lifestyle, we suggest her to stop snacking in between meals, pick up a good hobby to divert her boredom, and encourage physical activity, such as exercise. Studies have shown that 30 minutes per day for 5 days per week is sufficient. This is to ensure a long-term weight loss plan. We may also have to initiate pharmacological treatment if there is no improvement and her BMI is 30 kg per meter square or 27 kg per meter square with an obesity-related comorbidity. The second issue is her high blood pressure. According to guidelines by Ministry of Health Malaysia, we have to initiate pharmacological therapy and assessment of global cardiovascular risk. It is also very important for us to manage the obesity because studies show weight reduction can also reduce blood pressure. For every 1 kg loss, there will be a reduction of 2.4 and 1.5 mmHg in systolic and diastolic blood pressure respectively. It is highly recommended for her to do self-monitoring for her blood glucose and her blood pressure level on a daily basis. If Mrs. B is planning to get pregnant, she needs to be counseled for better control of her diabetes. Remember, medication may also be contraindicated during pregnancy. We also have to reduce the risk of getting eclampsia or any adverse pregnancy-related outcomes. Last but not least, as a preventive measure, we can also check her family members for diabetes because a favorable and early prognosis will give a good chance of treatment success.